like to thank Dr. Venkatesh and Dr. Manavi for giving us this opportunity. So we know actually the definition of endophthalmitis since morning we have heard at least 10, 15 times. It can be exogenous or endogenous. Especially in case of exogenous, we come across very commonly not only the post of endophthalmitis, especially the active age group. We have got a lot of children and young adults coming with the trauma either in the workplace or in the play area. And especially in case of children, they come with vegetative material, which is very difficult. We will see some of the cases. And the risk in post-traumatic endophthalmitis, especially in open globe injury, is very high. The bacterial spectrum is also very different and it is very difficult to manage. Very commonly, especially, we see it's bacillus spectrum, which is almost resistant to every other treatment, whatever you do. And if the patient recovers, most of the time it is because of luck, I feel. And in case of gram negative, we commonly come across the Pseudomonas species, which causes very fulminant infection in these cases. So the basic idea is in case of any traumatic endophthalmitis, don't delay. Even a delay of 4 to 6 hours can lead to a blinding of that eye in children. So the risk factors in case of traumatic endophthalmitis are when we delay the primary repair. That is more than 24 hours. In fact, in all our cases, this is one condition where we take it up as an emergency. When the patient comes with open globe injury, immediately at least the globe is secured. The primary repair that is done within the first 24 hours. There are two reasons for doing that. One is to basically maintain the integrity of the eyeball. And second thing is to prevent the infection. In all these cases, even in a small corneal tear repair, it is our protocol to inject, even if there is no infection, we go with VCV in all these cases of open globe injury after the suturing, because it always prevents the occurrence of traumatic endophthalmitis following open globe injury. Some people don't do that, but there is a chance that the patient can have infection. And retained intraocular foreign body, especially it is contaminated with soil and other thing. And if it is an organic material, 100% they go for endophthalmitis. In case of iron foreign body, to some extent it is fine because when there is a chiseling and the hammer happens, probably the iron piece may be hot and can be sterile. It usually causes mechanical damage and metallosis, and very rarely or not very commonly it causes endophthalmitis. If there is a rupture of lens capsule, that is a risk factor for developing endophthalmitis. A large wound size, don't ask me how large, it is large. If it is large, there is every chance that it can go for endophthalmitis, and vitreous collapse has to be managed well. As we have already discussed, this is one of the worst organism we have come across, which causes a very virulent infection within 24 hours, and it can have some systemic what do you call illness along with. The symptoms are same, almost similar to what we are seeing, but the most important thing is we have to be very careful in examining the patient. In one of our centers, actually, the patient went. There was a small lid tear which was noticed by the both the pre-op optometrist as well as by the surgeon. And the attending physician, he has written a small subconjunctival hemorrhage. The vision was 6/6. Patient was sent home on topical antibiotic. Nothing was done. Believe me, next day, this happened on Saturday morning, 10 o'clock. Sunday, the patient came with fulminant endophthalmitis. No X-ray was done, and the patient had a very bad endophthalmitis, lost the eye, and in fact, it became a medical legal case. So whether it is what do you call open globe injury or even closed globe injury, if the history is not very clear, whether you suspect a foreign body or not, X-ray, orbit, PA view is mandatory for all traumatic cases for medical legal purpose. So any case of open globe injury, you have to do the X-ray orbit. Doing an ultrasound is not a bad idea, provided you are not expelling the contents. And if you're very sure that there is no metal, you can go for MRI. Otherwise, metallic, if you suspect CT, use a very precise, what you call, diagnosis. Ultrasound is a wonderful investigation in case of any trauma. The reason is it doesn't not only says about the status of the retina or the location of the foreign body, it tells us about the collateral damages, whether the patient has got vitreous hemorrhage or whether the patient has got retinal detachment. Everything is very precisely shown by ultrasound. In fact, if you are doing an ultrasound and if you can precisely locate and you can precisely measure the size of the foreign body over a period of time, that means you have become an expert in ultrasound sonography. So this, again, care should be taken not to expel the contents. We have to be very gentle in doing that. In case if you're not able to do that, don't do that. Anti-segment foreign body, everybody says we can do anti-segment, what do you call, UBM. But UBM should not be done in acute cases because if the wound is open, we usually use a water bath. That can also lead to, infection. But UBM is recommended provided the patient comes after a very long time when we are not able to locate the foreign body, if it is somewhere located in the angle of the eye. So as I was saying, 0.06 square millimeter is fine for a CT to pick up. But we have to tell that depending upon the size, they have to reduce the slice cut so that it can be located precisely. And this is very important because many times we think that foreign body is within the eye, but it will be in the coats or outside the coat, and then it becomes a big mess for us. So this has been discussed a lot. Some cases, this is one case of a 57-year-old female. She had the history of cutting the wood. So we have to expect something in all these cases. This was an injury with organic material. And we can see there is a corneal, self-heal corneal tear. But when we go inside, we should always be very clear, careful in expecting some wooden foreign body in these cases. We can see there are a lot of echogenicity of the vitreous, but minimal thickening of the RCS complex. As soon as the patient comes, as a preventive thing, we go for vitreous tap in all these cases because we are buying the time. And here just will deviate for some 10 seconds. Anybody who's operating, injecting intravitreal antibiotics is not a rocket science, number one. And even if any anti-segment surgeon, if he wants to refer his case to a posterior-segment surgeon for a endophthalmitis, the first thing you can do is you do a vitreous tap and inject intravitreal antibiotic, maybe VCV, vancomycin or voriconazole, and then you refer that a particular window with antibiotic can take care of. But by the time you refer without this preliminary vitreous tap, the infection can become worse, number one. And number two, I don't have any business interest. If you are interested, I think they have a stall outside RO Lab. I think they have displayed something called E-kit. It can be emergency kit or endophthalmitis kit. It contains A to Z of the things required for doing a vitreous tap right from the speculum to the drape, and it is a single dilution. So you don't need to be really Ramanujam to calculate the dose. Actually, just inject whatever is recommended, take 0.1 ml and inject. And by that time, you can prevent the progression of endophthalmitis. So going back to this case, you should always expect something. So this case, you can see there is a self-sealed corneal tear. So we have gone for a poor vitrectomy because a lot of exudation. So nowadays, most of these cases, not most, almost all cases, we go for a complete vitrectomy in these cases, including complete vitrectomy, meaning basically we induce PVD so that nothing is left. Previously, core vitrectomy means theoretically 50% of the vitreous is removed, or once if you see a good red glow, or once if you see the optic disc, then we stop it. That is the core vitrectomy. But here now we go for complete, in the sense we induce PVD. So here after doing, I was expecting something in this. So we just aspirated the exudate, and then we gently, I usually use the Sinski hook for gently teasing the exudates from the AC. Then we washed that area. Now you can see that's a small wooden piece, okay? With the help of a 23 gauge forceps, that wooden piece was removed. The reason I'm saying is if just we would have washed the AC and if we would have left that wooden piece inside, you can see the small wooden piece. This case wouldn't have become all right at all because there will be recurrent infection in these cases, and we will have been giving a recurrent, injections, repeated injections without any use. So this case did well actually. So this was POD1. Almost everything is fine because the focus of the infection was removed, and it improved almost 6-9 in a week's time. So you have to expect wooden foreign body, especially this is very common in case of thorn injury, because when the thorn goes out, when you pull the thorn out, the outer cap of the thorn stays always inside the eye. That keeps on giving problem to the patient. So this is another case. You can see the foreign body. Yeah. So we have done the lensectomy also because the lens was subluxated, and the lens was quite soft, so we have removed that with the cutter. Otherwise, if it's hard, we need to use a fragmentome. And a complete examination is required. Sometimes we can do a fluid air exchange, and that gives a panoramic view for localizing the foreign body. So I think the foreign body was in the past plana, so I couldn't localize that properly in this. So once that was removed, the outcome was good in this case. And the last case which I would like to show is like the carelessness of our people actually. A 14-year-old boy, I think he was playing with, it was not a pit actually, but he had the injury with the crane's beak. He came with, open globe injury with a lot of vitreous opacities. The vision was very poor. The lens was subluxated. As I said, X-ray is mandatory in all open globe injury for the medical legal purpose. X-ray PA views, again, I'm reiterating, is very mandatory because you can save your life by doing just an X-ray. So we have done the vitreous tap. For the case worsened, we went for the corneal tear repair. Again, it was not clearing. Then we went for culture. This was very, very unusual for us. This was one of the rarest reported case where we could find the cholera inside the eye actually. But there was no what you call rice water discharge from the cornea, fortunately. So the exudates were very normal. So we went for core vitrectomy in this case. I think I don't have the video, but this was the final outcome of this case. This case did very badly. You can see the complete retina folded over and silicon filled eye. And what you see here in this yin-yang type is basically the bare choroid. And the other cases, very often again we come across. This was the chain of a child. The child was playing like this, and one of the, what do you call, the end of the chain entered the father's eye. So this patient had a large intraocular foreign body with a severe infection. So the view was very bad actually. So we completely removed. After that, we could localize the connector of the chain. And then this patient fortunately improved up to 6/24. So finally, what happened is, even though the partial recovery of the vision was there for the father, the child could recover the chain completely and reuse it actually. In this case, that is the only advantage of doing this. So we expect all these unexpected in these cases. And these are all very common, which we come across because all of us, including me, you, everybody, all Indians, we all suffer commonly from one syndrome called, what is that? Any idea? That syndrome is called as "it will not happen to me" syndrome. We all strongly believe that it will not happen to me because when we go in the bike, we will not wear the helmet because our head is very strong. It will not happen to me. We will never wear the thing. So this is a case very commonly we come across, especially by the electricians, the plumbers, or the people who are working in this, what you call, blacksmith area. We can find a lot of this hammering and chiseling. If it's a large foreign body, it is always easy to identify. Sometimes it's very difficult. So here I couldn't find the foreign body. So we did a fluid air exchange. As I was saying, we can get a panoramic view. I think this is some other case. I am confused. I think there's some other case where we could find the foreign body, and then usually in all these cases, because of the infection, we go for the silicon oil removal. So this was a male patient. So they come with something like this. Endophthalmitis completely gone cornea, but we don't have the facility for what you call endoscopic vitreous surgery. So we don't have much this thing of this thing, what you call K-Pro. So we go for a complete graft, corneal graft surgery. So this patient underwent therapeutic keratoplasty. We can do simultaneously also or sequentially. In this case, actually, we went for a sequential core vitrectomy. The reason is we don't want to disturb the integrity of the graft because if the pressure is increased, there can be cheese wiring. So we waited, gave the antibiotic, but on day one, we could see that there is increase in the exudates, even filling the complete area. But we went for a 23 gauge core vitrectomy in this case. And this was a case of keratoglobus, and the patient had some suture removal. Fellow eye had only 5/60 vision. So it was literally abandoned by the cornea people, but we insisted that the patient should go for therapeutic grafting. So a complete vitrectomy was done in this case. This is a bit unnecessary, like going to the periphery and removing the cortex in this case. I mean, the vitreous in this case is unnecessary because that's the time we create iatrogenic breaks. So we went for culture, nothing was found. The eye was filled with what do you call silicone oil. This was POD1 with a 1/2/60 vision. Now we have got almost 6 months follow-up. The patient is having somewhere around 5/60. A person with the 5/60 in the fellow eye, around 5/60 is not a bad vision too. So never let it go. Actually, this is the patient's current status with the fundus seen with some 5/60 vision. So never let go things. So in all these trauma cases, there are certain challenges while doing vitrectomy. It is not as simple as in case of post-op endophthalmitis. Rarely we'll have that what you call melting of the cornea and other thing, which makes our life difficult in post-op. But in trauma case, every case is different and every case is challenging. So doing a vitrectomy is very difficult in these cases. And when you're doing a hyaloid removal over the necrotic area, we have to be very careful because that can lead to retinal detachment. PVD has to be removed completely, but at the same time, carefully to remove the complete load. And you should not be very aggressive and don't go beyond the equator because that is the time we create a lot of damage to the peripheral retina. It can be just trimmed actually. I'll just skip all these things and we'll go to the last slide. So in summary, like we have got a lot to do in case of trauma cases. There is always a high chance of surgical complication, especially when you're suturing the open globe wound. You have to be very careful because many a times, actually, when we are doing the sclerocorneal tear, we can find the retina in the section and it is incarcerated. And that makes our life very difficult when we are going inside the eye. The corneal haze, the edema and the folds, as well as the corneal abscess, makes the visibility very bad. In some cases, you can use K-Pro or you can go for therapeutic PK. Exudates in AC also difficult to tackle and they keep recurring also, and that also makes our life difficult. And pupillary and the perilentricular membrane. And the most important thing is choroid will be very thickened in case of fulminant infection. So you'll have to use a longer cannula to we see the tip of the cannula inside the eye. Otherwise, we'll be complicating the surgery. And the vitreous is also very sticky and there'll not be PVD, especially in case of children, difficult to remove. And the retina, because the infection will be very friable, so we should be very careful not to create any iatrogenic detachment or carrying the detachment. So with that, we'd like to end this. Thank you. Thank you once again.